Right now. We live? Okay, can you guys see us?
Yes, we have.
Okay, can we show the fluoroscopy, please?
Tell us what you are working on.
Yeah, so we have this patient that had metastatic pancreatic cancer and came with obstructive jaundice and a gastric outlet obstruction. She had a GJ yesterday during the course, and today we're going to convert the percutaneous drain in the biliary tree with a hepaticogastrostomy. So in order to achieve that, when somebody has a perc drain, the biliary tree is decompressed. So the first thing we did was to inflate the biliary tree with normal saline. Once we achieved that, Dr. Asharqi was able to put a 19-gauge needle into the left hepatic duct. I don't know if you can see the fluoroscopy. And I already advanced a wire through the perc drain and through the EUS-FNA needle so that we have access. So now it's very important to understand what we're going to be doing. In order for us to successfully do the hepaticogastrostomy, we're going to need to sacrifice the perc drain. As you can see here, the needle interjects with the trajectory of the perc drain. So in order for us to be successful, now that we have wire access, we're going to give up on the percutaneous drain. Okay? So the way to do this is to unlock the system. The fastest way to unlock the system, can I have scissors, please? Scissors? Is to cut the percutaneous drain at the base. That will unlock the system and you can then remove the perc drain. And after that, we're going to exchange the needle for the cystotome to create the track allowing the hepaticogastrostomy. So here they are now, they're giving me the scissors, thank you very much. So I'm going to unlock the system right here at the base by cutting it. So this is something you do only once you have access, obviously. Here it is. That's it. Okay. X-ray. Where's the camera? X-ray?
Yes.
Can you zoom on the pigtail?
I see.
So when you cut the distal end of the catheter, you unravel the perc drain and you can remove it. X-ray, please. Now let's do X-ray. So you see now we have the wire buckled on itself for safety through the needle. So now what we're going to do, I'm going to do an exchange with Dr. Asharqi. You have to remove the needle from the biliary tree. Okay, I have the needle, the wire here. Okay, you have to remove it.
There is minimal lift system dilatation that allow you to do HGS.
Well, I mean, you know, you can inflate, if you can get into at least a 2 millimeter branch, you should be able, X-ray, slowly, X-ray. Okay, you have to go slowly, Asharqi, because this is, as you can see here, okay, we don't want to lose the access now. So as I said, at least a 2 millimeter biliary tree branch is sufficient. But once you're in with a needle, you can then inflate it. Here, it was a little bit more complicated because the perc drain did a very good job. So now Dr. Asharqi is going to focus his attention onto the wire. Where's the wire by EUS? We need to see the wire on EUS. So you have to rotate the shaft to make sure you see the wire on EUS, because this is how you're going to be able to advance the gastrostomy. I mean the cystotome. X-ray. Okay.
We start with the system. So would communicating the right and left system communication would make a difference in choosing the type of stent and the left?
I mean, if we do a hepatogastro, you're gonna go for the left. That's the way to do it, and you gotta try to find a branch that is not too superficial over the wire, and we're gonna do live fluoroscopy while we're advancing the cystotome and the EUS. Okay, let's go live fluoroscopy. Fluoroscopy. Okay, let's go.
Okay.
Let's go.
Possible to ask a quick question?
Yeah, go ahead.
Is the
This is palliative. It's metastatic pancreatic cancer.
So, and what is your preference here, anti-grade versus?
Well, we're gonna do hepatogastro because he has a gastric ulnar obstruction. You know, basically you can't get to D2 anymore, so we're gonna do a hepatogastro in this case.
So, sorry, I meant anti-grade from AGR.
Anti-grade, but with a transhepatic stent. So basically, it's gonna be hepaticogastrostomy. Okay, let's go.
Okay.
Yes,
Go.
go ahead. X-ray, X-ray, X-ray. Go, 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 go,
Okay.
go. Are you? No, you have to go deeper. No, deep enough. Keep going. Keep going. Okay, now you're in. If you're really in, you should be able to advance without cautery. Can you advance without cautery? You can. That means you're in. See, so that is the most important trick. I don't know if you guys pay attention. Once you're in the duct, you have to stop cauterizing and advance without cautery. That is the signal that you have reached the biliary tree. Now what we're going to do, we're going to exchange, we're going to remove the current, and we're going to exchange the hepaticogastrostomy for the stent. Can I have the stent flush with contrast, please, and lubricate it?
So, what is the length
Con-
of the stent that will be used?
Scopy.
Very good question. It's a 100 millimeter stent
Scopy.
from Taiwan. X-ray, please. X-ray.
Sorry.
Okay.
That is a gold stent.
Yes, exactly. We're going to flush it, please. Flush it. Okay. Here we go. Alrighty. So you see how I'm trying to be safe. I buckled the wire on itself. Okay. So that like this we have leverage and we don't lose access. But I want to remind everybody that this part of the procedure for Dr. Asharqi is by EUS. You know, so you have to constantly make sure that the wire is in the alignment of the biliary tree, because if you're tempted not to look at the EUS anymore, okay, and you exclusively look
Sorry.
by fluoroscopy, your angle will change. And remember, EUS is a tangential puncture, which means you're going to change the way that you're going to have the access, and you will lose the benefit that you just created by creating a fistula. So you see now he is still focusing on torquing the scope, okay, to the left, so that he can put the wire in his field of vision by EUS. That is what we call, did you flush with water? Okay.
You use the segment 3 to access the
Yes, yeah, the
Yes.
majority of the cases is the best way to do it. So we advance in the stent now over the wire. We have a nice track, and as I said, we have to respect the angle of access into the biliary tree. It's what I call the rules of engagement by EUS. You have to respect the angle that you started with to create the hepaticogastrostomy. So you see, he's now. Can we see the EUS? Are you guys watching the EUS too?
Looks right.
So this step is usually tricky to because we easily may lose the position.
Exactly.
Of this step. So how to prevent this?
You have to always have your eyes on the wire. Always.
X-ray?
By EUS. So the X-ray help, but really the most important thing is to torque the scope. Here it is. Put the wire in the field of vision, even if you have to ask your assistant, you see, to help you. And you're going to advance now the stent over the wire. Here it is. Advance the stent over the wire.
X-ray.
Go ahead.
X-ray.
Here it is. Advance. Here, you see? That's the most important thing. And then you have to advance. Okay, so now you are in the biliary tree. You don't want to go too deep. You don't want to go too deep. I think this is pretty good. I will pull out just a little bit. Okay, so that pull out the stent a little bit. Pull out. Retire un peu le stent. Retire, retire, retire. Voilà, c'est bon. And now what we're going to do, very important when you do hepatogastro,
Now we have the endoscopy view.
is to deploy the stent, and you have to see the flange, the inner flange, okay? You have to see it flaring.
Yeah, the endoscopy view is not visible.
Can we do the, well, we don't have endoscopy view yet. So, okay, X-ray. I need the fluoro, please. Okay. You have to pull back the stent a little bit. Retire un peu le stent. Retire un peu le stent. Retire-le. Viens.
Ouais, je retire.
Un peu. Voilà.
This is the uncovered part.
Yeah. Ok, retire-le encore un petit peu. Ok. Maintenant, il faut que tu endo et t'écarter de l'estomac.
Can we say the...
Can we shift to endo, please?
How do you decide about the size of the stent?
Yeah, that's a very good question. The size of the stent is obviously based on the biliary tree. That's why we want to make sure that il faut que tu t'écartes un peu et voilà. Attends, pas trop vite, voilà. Ok. Endoscopy, please. CO2, please. CO2. CO2 is on or no? Ok. Et un souffle.
Oh,
Un
je suis
souffle.
en train d'insuffler pour moi.
Ok. X-ray.
The wire is still in.
Yeah. It's very important to keep the wire until the very end. You see here we have a nice access here. Here it is.
Oui, good.
Voilà. Okay. Very nice hepatogastro. So now you can decide. You could put a pigtail if you want. Okay.
We do a contrast to confirm that.
We can do that. That's fine. Okay. So let's leave the wire. Attends. Let's leave the wire. Garde le guide. X-ray.
No, it is necessary to put...
Like this. You have to advance the scope down.
So into my question,
Voilà.
how do you decide the size of the stent?
Yeah, so we have removed the inner sheet of the stents, and over the wire now we're gonna do dilation. We were able to play with the wire. Can we show the fluoroscopy, please? Can we please?
Just having a little debate in the room here.
Yes.
You probably got just over a centimeter stent coming into the stomach. Would you consider extending it out with another, maybe a fully covered metal stent?
Well,
Patient vomits or that
well, we're gonna dilate first. I think that's the first thing is to dilate, to make sure that the stent is basically completely deployed. That's very important, but actually that's gonna allow the stent to stay in place. And then after we're gonna decide if we're gonna extend it or just double pigtail it. Because once you double pigtail the stents, you basically give all your options open and you are safe. Can we dilate, please? This is a balloon that goes all the way to, okay, to 8 millimeter. Good, that should be fine. Let's dilate the stent here. Dilate to 8, go ahead. And then I need a 7 French by 15 centimeter.
Uncovered metallic.
You want another one?
Down.
Michel?
Yeah, we could do that if you want. Yeah, sure. Let's dilate.
Okay.
Pass the wire because.
Okay.
It's already passed the deal.
I know. Dilate. Keep dilating. Keep dilating. Dilate. Dilate. Okay, this is good. Balloon down. Balloon down.
Can we...
You're gonna have to go deeper.
voilà.
Okay.
Can
Balloon
we-
down. Yeah.
You need BTC with advanced EUS now, with method for manipulation.
No, you don't need PTC. You just need an advanced endoscopist. X-ray. Can you advance a little bit the balloon?
Only 10 centimeters.
Go ahead. Okay, then we're gonna put a.
Good. Now it's the candidation now.
Okay, dilate here. Dilate here. Go ahead. Dilate to 8. Go ahead. Here it is. This is good. Now.
You wide out into the duty member.
Okay, this is very good. Now it's well dilated. Okay, this is good. Balloon down. Okay, now what we're going to try to do is to place a uncovered stent through the covered stent crossing the ampulla. Yeah, so what I'm going to do first is secure more wire. Here it is. And we're going to exchange. So Dr. Asharqi is going to pull the balloon completely deflated, please. Okay. Yes. Yeah, of course we know that. That's why we want to put a uncovered stent across the ampulla now. So we're going to have a double drainage, hepatocogastro drainage and a drainage in an antegrade fashion. Okay, can I have a, let's say, 10 by 60 uncovered metal stent? What do we have? X-ray?
So back to my question.
Yeah.
How do you decide the length of the stent?
So the length of a stent is actually always decided on how deep you are in the biliary tree. So here we're very, very close to the hilum. So when you're so close to the hilum, 9 times out of 10, you need a 100 millimeter stent. If you're a little bit closer to the liver, I mean the stomach from the liver, you can get away with an 8. It's extremely rare with the hepatogastro to use something shorter. Because if you use something shorter, you're going to come up very, very, very close to basically have the stents migrating out from the stomach. So it's better to go longer than shorter. So really here we are borderline, like really borderline. So
Passing the metallic stent now after deploying the stent, risk migrating this.
well, that's why we dilated. That's exactly why we dilated. So now that we dilated, we should be able to advance the uncovered metal stent easily. But if there's any obstacle, we will stop, obviously.
One suggestion is if the delivery of the uncovered stent is 6 French, there's a possibility it may cross. A 7.5 French or 10 French is difficult to do a cross.
Okay. Yeah, I mean,
French delivery catheter, there is a possibility we may be able to go across the.
yeah, I mean, what we may have to do is to dilate the distal biliary obstruction. So I think I want to see what kind of uncovered stent you're going to give me and how pointy it is. 8 only available?
No, 15 is better.
Okay. No, we're talking metallic. He wants to put a metallic uncovered
Ah,
across the ampulla.
ouais.
Okay.
Yes, good. Okay.
So,
12 millimeter, 12 centimeter. 6 millimeter.
okay.
12
So,
12. 10?
okay.
Huh?
Okay. So
10
as
by-
I said, we need to decide, are we doing double pigtails or are we doing an uncovered metal stent? I thought we were doing an uncovered metal stent.
If we do uncovered, it's
Uncovered metal stent.
12
Non,
centimeter.
métallique.
Métallique, 12 cm. Ils ont pas
Ils n'ont pas.
Bon, 10 cm, mais c'est pas...
Voilà, this is good. 10 by 8, it's good. All right, let's flush it with water and let's
Sorry,
try
look,
that.
Look,
10 by 8.
Rajesh was just suggesting a
Yes.
6.5 French delivery stent available. So we have a
Yeah.
stent in UK and that's very thin and that was also
Do we have a 6 millimeter stent delivery system around or no? We have what? No, we need 6.
6. And the catheter porter must be 6 French, catheter porter. What is the catheter porter for this? Catheter porter. Porter?
This is, I think it's 7 French, I think.
Catheter.
Let me see.
Porter catheter.
I think it's 7 French.
Huh? 7?
8 French.
8?
8 French,
Oh.
yeah. Do you have a 6 millimeter one? Yeah.
Uncovered.
The delivery system.
Hmm?
The patient is supine.
So that's the position you prepare.
Oh yeah, absolutely. I do 99% of my ERCP supine. It's
So the other thing is so assume you do decision. Why would choose transcapillary or anti-grade instead of double thick?
Well, I mean, we can go either way. You know, I mean, I think if we want to go cheap, we'll go double pigtails, obviously, a very long double pigtail, and that could be a good option. But I mean, you know, if you want to absolutely cross with an efficient stent, you will go with a metallic stent. It's more expensive. I don't think there's any data to show that one is better than the other. I think if we don't have a 6 millimeter, you want to put double pigtail?
No, no, no. We put metallic stent. It's better.
Okay. All right. So let's do metallic stent. Can I have that 8 millimeter stent and flush it with a lot of water, please?
No, no. It's better to
Yeah.
put metallic stent because we must cross the stenosis.
Okay.
Distal stenosis.
Let's flush with water.
Distal. It's better to put. We will try to put stent until duodenal, luminal duodenal. It is the main.
Okay.
Yes, okay.
Any clinical difference putting a transpapillary metallic stent or just anchoring this stent with double pigtail?
I mean, there's no data showing that one is better than the other. My understanding is the preference in this institution is to place a metallic stent across the ampulla. So that's, but I don't think there's any data showing that one technique is better in this specific case. So we have a lot of wire here.
There was a recent paper out, I think, that double drainage may have slight advantage because you have access and distal stent has no good answer. So I think there is
All right.
some advantage to do it.
X-ray. Go ahead. Okay, this is going. This is going nicely so far. Okay. Okay.
Oh, oh, yeah.
Okay. Yeah.
Do we know what is the ampullary?
X-ray.
X-ray.
It is a resistance here.
You're almost there, though.
Look. There's a resistance because on bute contre la sténose tumorale. Mais on va essayer de revoir.
Without a contrast, we cannot really tell if we pass the ampullary area or no.
Yeah, I know. I mean, we can try to see if the stent can be opened here. Okay. Can try.
1 minute, please.
Yeah.
If we cannot pass this stent, we cannot
That's
pass
it.
double
That's it.
pigtail.
That's
Okay,
it.
yes.
Okay. Now you're gonna pull gently the metal stent. You have to pull on the. Tu dois retirer un petit peu le metallic stent contre la sténose. Voilà.
Is this the uncovered stent you're using now? Transpapillary?
Ok. Tu dois.
Ah, ok, c'est bon.
Il faut que
Tu
tu.
largues,
Oui,
t'es
je
en train
l'ai,
de
je
larguer.
l'ai, je l'ai.
Ok, c'est bon.
Ok. Il
je
faut que
largue.
tu. Voilà.
Ok.
Ok. Il faut que tu tires un petit peu.
Oui, je sais, je t'entends.
Ok, un petit peu. Voilà. Pas trop. Pas trop. Here we go.
Good.
Okay. So I think we have very good drainage right now. At this stage. Okay, at this stage, tu veux garder le guide ou tu veux enlever?
Bon, je crois. Attends,
Okay, I think we have very good drainage. So we're gonna abandon the wire, and you can see now we have a full drainage of the biliary tree, crossing the structure in an integrate fashion, and we have a hepaticogastrostomy. Okay. All right. Thank you, everybody in this room. Beautiful work.
Great.
Okay, with Abed here, giving the advice of going with the metal stent, and looking forward for next year.
Yes. Thank you.
Thank you so much, everybody. Excellent. Thank you. We need to make a picture with the whole team. Beautiful. There it is. Voila. Okay, here.
ها هي لفت lateral شوي